Hello, and thank you for joining us for this broadcast, which accompanies the Journal of the American College of Cardiology, ACHD Spotlight issue, published with the recent release of the 2025 Guidelines for the Management of Adults with Congenital Heart Disease. My name is Yonatan Buber, and I am an attending cardiologist at the section of Adult Congenital Heart Disease and a professor of medicine here at the University of Washington Medical Center in Seattle, and a member of the JACC ACHD Consult team. Today, I have the special privilege of speaking with the world-renowned Dr. Pat O'Gara, who is a cardiologist at Brigham and Women's Hospital, professor of medicine at Harvard Medical School, and a past ACC president. Dr. O'Gara contributed a very interesting piece to this current issue of JACC entitled 2025 Guideline Recommendation for the Treatment of Adult Congenital Heart Disease in comparison with the 2020 guidelines for the management of patients with valvular heart disease. Dr. O'Gara, thank you so much for joining me today. You have obviously been caring for patients with valve disease for many years, and I've been caring for adult congenital heart disease patients for the past decade and a half or so. And so based on your contribution to this JACC issue, I think that it is fair to say that both of us recognize the nuances of this unique patient population. And so I thought that our conversation today will evolve mainly around if and how the care of ACHD patients with valve disease should maybe be refined and individualized in light of the recent publication of the 2025 ACHD guidelines. And so one of the features that makes ACHD population, the ACHD patient population unique is that many patients are young, and factors that are perhaps less prominent in older patients become central when considering valve surgery. And these include decisions that affect family planning, sports participation, and career choices. And so in your view, and based on the guidelines in your publication, how should shared decision-making be effectively operationalized within the guideline-based care of this population?
Well, Yanni, thanks for that question. I think both the Adult Congenital Heart Disease Guideline and the Valvular Heart Disease Guideline emphasize the importance of the multidisciplinary team. And your question is really how to operationalize that. I do think that each of the institutions that participate in the care of patients with adult congenital heart disease likely have their own strategies to optimize operationalization, for example. But it's very important for the clinician caring for the patient, who likely knows the patient better than anyone else on the team, and oftentimes the nurse coordinator or the advanced practice practitioner who is participating in the care of these patients, can influence the conversation among interventionalists, surgeons, electrophysiologists, and others who are involved in the care of these complex patients. And I do think that it takes an iterative process by which decision-making can be focused and then explained in understandable terms to the patient and family. I do think that these are very complex decisions in younger patients, and oftentimes we have to make trade-offs that are not pertinent to the older adult with valvular heart disease. We have to make decisions, for example, to palliate rather than to improve substantially. We have to make trade-offs between choice of a prosthesis, for example, that would entail the use of anticoagulation, and a desire to become pregnant. Now, there are reproductive health issues that have to enter into these equations. So I'm very, very happy and to see the emphasis on multidisciplinary team shared decision-making with patients. I do think that that's one very important take-home message from these guidelines.
Yeah, I agree. I think that when we were sitting together and trying to come up with things that would make our guidelines a little bit more special and unique to this patient population, this theme of shared decision-making is something that kept coming up almost in every single topic that we covered. And this kind of leads me to the next question. You know, a key theme of your manuscript is cross-referencing between multiple guidelines. And so, when we sat and thought about how our guidelines should not overstep over, the valve guidelines, or in some cases, the aortopathy guidelines or others, we were thinking how to make our guidelines stand unique in between those other topics. In your mind or in your opinion, what core principles should clinicians keep in mind when applying ACHD, valve, earotopathy, or any other guidelines to young patients whose early decisions have lifelong consequences? And maybe a second part of that question would be, how would you guide clinicians to jump between those guidelines when trying to make decisions for their young patients?
Well, I would be very interested in your perspective on this as well, Yanni. I think that there are some foundational principles that clinicians need to follow, and to be as objective as possible about the indications for an intervention other than medical therapy. Those indications, of course, are dominated by symptoms and concerns about progressive biventricular dysfunction, and I would emphasize biventricular in the adult congenital heart disease patient population, as well as some of the nuances about the risks of sudden cardiac death among some of the subpopulations of patients with adult congenital heart disease, with which adult cardiologists are much, much less familiar. So I do think that one of the foundational principles is to be clear regarding the indications for an intervention in a young person that will have implications for lifetime management and potentially for complications related to the intervention itself as a trade-off against complications related to the natural history of the congenital heart disease lesion. I'm thinking, for example, about the need to perform bioprosthetic valve replacement in a young person who wishes pregnancy and then is saddled with the reality of early structural valve deterioration and the need for a second procedure, third procedure, and sometimes a fourth procedure. So I do think that we need to be sharp and clear. But we also need to understand that the evidence base on which we make these decisions in young persons with adult congenital heart disease is relatively thin compared to the evidence base for older adults with valvular heart disease, as a consequence of which you'll see the level of evidence in the Adult Congenital Heart Disease Guideline predominantly be one of C, either limited data or expert opinion. But this is exactly the area in which clinicians need guidance from the experts. And I think that we should not spend too much time bemoaning the fact that the state of evidence is this. We should, I think, applaud the input of experts who can help clarify how to make decisions in complex situations.
I completely agree with that. I think that seeing as many expert opinion type recommendations was a little bit intimidating to me and to many of us who were sitting on this guideline writing committee. But at the end of the day, we need to just accept the fact that ACHD patients are not included in many of the large randomized clinical trials that are out there on almost any topic, from valve intervention to pulmonary hypertension medications. They're just not there. And within our small patient population, large randomized control trials are almost not a thing. So, if you would see 1,500 patients in each arm in those large trials that are out there, in our adult congenital heart disease world, we're looking at good trials, including maybe 150 at the most, 200 patients in each arm, and we're very happy with those studies.
Yeah.
And I think that you're absolutely right. We need to accept this fact. We need to sometimes rely on our experience as ACHD providers and just saying the guidelines, this is what we see, this is what we know. We know that this is how this condition behaves. And even if we have a retrospective study on 20-something patients, we just know that this is how things work, and this is how we make, or based on this, we make our recommendations. Let's dive a little bit into more specific lesions. And I think two of the more complex ones, when we think of the interactions between the valvular guidelines and the ACHD guidelines, are aortic valve disease and mitral valve disease. Because pulmonary valve disease, we've been dealing with that for many years, especially in tetralogy of Fallot patients and congenital pulmonary valve stenosis and the tricuspid valve disease, as you highlight in your piece. There's some distinction between Epstein's anomaly and other types of tricuspid valve disease. But I think aortic stenosis is an interesting condition because we are often encountering patients with bicuspid aortic valves or unicuspid aortic valves and related aortopathies. And we find ourselves again needing to kind of jump between the guidelines of valvular heart disease, aortopathy, and the ACHD guidelines. So when you're thinking about those three and trying to decide on a young patient who perhaps needs a valve replacement, an aortic replacement, and shared decision making, where and how would you guide your fellows or younger counterparts who work with you to read those guidelines and guide their recommendations to these patients?
Sure. Well, I think this question gets back to one of the previous ones that you asked, and that is the interoperability of the guidelines, so as to avoid redundancy and, as you put it, to stay in your lane, for example. I think that I would refer my fellows and other clinicians to the Adult Congenital Heart Disease guidelines when it comes to considering how to manage young patients with bicuspid disease that happen to be pliable, that have high gradients and want to participate in sports, for example. Someone who is in their late teens or early 20s, in which case you might look at a situation and decide that balloon valvuloplasty would be an adequate palliation for that patient with that particular subset of bicuspid disease. But then if you're going to ask me to participate in a conversation about the need for valve replacement, that I think is a comfort zone for adult cardiologists with respect to the trade-offs between attempted valve repair in the aortic position versus bioprosthetic, mechanical, or a Ross intervention, with or without incorporation of the need to replace the ascending aorta, for example. If their coarctation is present, then it's definitely something I need to get back to you about which lesion should I take care of first. There are multiple lesions in series, for example, and a lot of nuances that adult cardiologists might not really understand. So I think this is a really fertile area for us to work together so as to provide the kinds of perspective needed to leave the patient and the family with the best set of options for them. And that, I think, also speaks to the need for us to have access to interventionalists as well as surgeons who are experienced in these matters as well, because certainly when it comes to a Ross procedure, as you well know, experience does matter. And these patients deserve the best chance the first time around so as to prevent long-term complications.
That's a very important point and good point about the Ross operation and centers experience and looking down the road for the patients. And to follow up on that, for congenital mitral valve disease, which is something that we usually encounter in the setting of a more complex type of congenital heart disease, sometimes in the setting of Shone's complex, for example. What are the most important, I guess, differences in how timing and type of intervention should be approached in younger patients with multi-level left-sided obstructions, in your opinion?
Well, I think that that's right up your alley. And I think that as an adult cardiologist, I would not really wish to pretend that I would know what the strategy should be. I think I might be guided by which lesion, for example, is the most important. And also understanding that with Shone's complex, and as you put it, multi-level obstructive lesions in small hearts and small spaces, there's only a certain amount of palliation that can be performed. And eventually we run out of options because patients have had multiple interventions, multiple sternotomies, for example, and are not candidates for traditional transcatheter therapies because of anatomic constraints. So I think, once again, this is an area where we need to rely on the adult congenital heart disease specialist and then work together about, well, here's the choice for the valve intervention, but we need to understand a little bit more, or I should say a lot more, about natural history and expectations based on your experience.
I think that's a good point. We are looking into exciting new technologies for the mitral valve, even in the catheterization lab. Maybe some novel technologies in the OR as well. And so when we think about the future of our patients' lives and how it would affect their their pregnancy plans and their work plans and their sports participation plans, we need to keep in mind the number of times that they're going to go into the OR and what valve would be the best choice for that.
Yeah.
And maybe to follow up on that, we frequently encounter the issue of choosing the right surgeon for our patients. And, surgeons who do adult congenital heart disease surgeries are people who are not easy to find. There are not too many of them. It's a very, very long and demanding training. And so, in your opinion, in that patient population, how important or how critical, I guess, is the presence of an adult congenital heart disease specialist in the OR or in the procedural room, for that matter, in the catheterization lab, in addition or maybe instead to a surgeon who's not necessarily an expert in that field?
Well, I think that you bring up a really good point. And the Adult Congenital Heart Disease Guideline and the Valve Heart Disease Guideline, as well as other policy statements from the ACC, have really emphasized the desirability of getting patients to centers of excellence, or getting patients to primary valve centers, or getting patients to primary ACHD centers. Now, it's not as easy as it sounds. There's obviously constraints that are imposed by geography, by insurance coverage, for example, and all of the other elements that contribute to the fractionation of healthcare in the United States. It's quite frustrating. But I think that most adult valvular heart surgeons can replace a bicuspid aortic valve without difficulty. But I think that if you're going to be talking about a Schoen's complex patient, a parachute mitral valve, a subaortic membrane, or supravalvular aortic stenosis, those are things that require more experience that is not typical for the person who travels as an adult cardiac surgeon. And there's no substitute, I think, for experts in adult congenital heart disease surgery, but it does narrow the choices that patients have available to them.
Yeah, I think that's another maybe another thing that distinguishes our little adult congenital heart disease community from other subspecialties, in how sometimes limited we are in the places that can offer a true dedicated adult congenital heart disease. And I think one of our missions for the next decade or so is to expand our presence in the community, and not just for adult congenital heart disease clinics, but also for adult congenital heart disease interventions and in the catheterization lab and in the OR. And this is something else that we try to highlight in our guidelines. I think that people should be seen and should be referred to adult congenital heart disease centers, and those big decisions on those multi-level lesions, on these complex, shunt lesions with pulmonary hypertension, on pregnant patients who have complex congenital heart diseases. The approach should be, always know where the closest ACHD center of excellence is and just try to refer your patients there. And at the same time, we're trying to find our way more into the community. This is a big part of our recommendations and the guidelines. This has been great, and I think that I want to finish with a question that I, as a first-time member of a guideline writing committee, ran into and spoke a little bit about with my colleagues. And this is, maybe stepping a little bit out of the just adult congenital heart disease world, but more into the general guideline writing committee's world. As we were writing those guidelines, it takes time, maybe a year and a half, and then it has to go through all these review processes. And during those review processes, new studies come out and new data comes out. And we start talking among ourselves, well, should we stop everything and, put this trial into our guidelines and refine and change. And by the time that the guidelines come out, it's been, a year and a half since we looked into the data. Do you think that there is any role, and maybe this is already happening and I'm not aware, do you think that there is any role for continuous updates for the guidelines, and not just the adult congenital heart disease, any guidelines. Instead of those, every 7 to 8 years publications with people waiting to hear what we have to say as experts in the field, and just having, people updating the guidelines continuously and having experts access them continuously to look for updates.
Sure. Well, I think, Yanni, you bring up a very important point, and the American Heart Association, American College of Cardiology went through a strategic planning process in the 2019 year that led to a 5-year plan, at the end of which the expectation was established that guidelines would be updated every 1 to 2 years based on the turnover in evidence to which you've referred. And there is a high premium to be placed on making guidelines dynamic, making guidelines relevant and current. And I do think that it is an enormous process. You've outlined the fact that it takes a year or a year and a half. And I think in that process, we need to be careful that data, once initially released, oftentimes need to be allowed to marinate so that one can actually take a little bit longer perspective on efficacy and safety, for example, particularly when it comes to non-randomized data. And that marination period can oftentimes take another year. And there's, I think, value to be placed on making sure that you get the recommendation correct, and do not reflexively respond to something that comes out and say, well, this must be good, because, of course, our field has been littered with things that really look good at first and then turned out to be contraindicated. Type 1C antiarrhythmics in heart attack survivors with PVCs, of course, being the best example of that. So I do think it's a balance, but I do think the AHA and the ACC have committed themselves to do exactly what it is that you envision.
Very good point. I think, the idea of studies coming out and needing to meet the real world data in the real world patients and providers is such an important point, which many of us tend to sometimes forget as we read those new exciting studies in publication. Are like, all right, let's get them into the guidelines.
Yeah.
Well, this has been really enlightening, Dr. O'Gara. Thank you so much for joining me today, and looking forward to having more collaboration between the different guidelines and working together to help our young patients with adult congenital heart disease and valvular heart disease. Thank you very much.
Thank you very much, Yanni, and congratulations to you and the writing committee.